Hey everybody, it's Dr. Ben Pearl and I'm with Zoe Wilson, and we are going to do sort of a lead into our Biomechanics Summit 2024. And I'm really excited to have Zoe with us. It's the first time I've had a woman faculty speaker, believe it or not, and she is one of two that I'm going to have. I'm going to have one from the U.S. and Zoe's from, well, I'll let her explain about her hometown and about her background with a master's in podiatric surgery theory. You guys do things a little bit different in England than we do here in the US, but kind of frame us a little bit with, you talked about the national health system and maybe more emphasis even more towards conservatism and things we can do rehab wise initially. I know one of your things you mentioned was the acquired flat foot. So tell us a little bit about maybe some of the differences, and then you can lead into a couple things that you're going to be talking about during the presentation.
Okay, so thank you so much, Ben. It's a pleasure to have an opportunity to speak to some US colleagues and some colleagues, of course, in the UK. And my specialism really is in musculoskeletal podiatry. And I took an interest in the adult acquired flat foot around about 4 or 5 years ago. And I started to see these patients coming in, patients that were on long waiting lists in the National Health Service over in the UK. And we kind of champion conservative management for these patients. And certainly when you look at the evidence base in type 1, 2A and 2B, certainly type 1 and 2A, we're kind of looking at conservative management, and that being custom-made foot orthoses and ankle foot orthosis. And the more I've kind of worked on this condition, it's also championing rehabilitation and the use of strengthening the posterior chain and the proximal aspect of the lower limb as well. And surgical intervention does happen in the UK, maybe not so much as it does in the US. And I know lots of the studies that I've looked at on this condition talk about surgical intervention from stage 1 on the Meissen classification, which is was essentially modified from Johnson and Strom's classification, and they kind of talk about surgical intervention certainly, but we're kind of saying, well, not everybody's a surgical candidate, and what can we do conservatively to manage these patients?
So there are a number of approaches that you use in your toolbox. I know bracing, the Ritchie brace in particular, is one of the things that you like, and I guess you've had some success with it. Can you address some of the successes and some of the things that have led to compliance with you? I do find some pushback with my patient population when we start talking about braces that go above the ankle sometimes.
Mm-hmm. I mean, I think it's difficult because ultimately you've got to have a patient that's going to be compliant in using the brace whenever they are weight bearing, and sometimes certainly for sporting activity as well. Now, lots of my patients are avid walkers. They get up here in the mountains and they just want to keep moving as much as possible. One of the problems with this condition is often when patients are challenging themselves with different terrain and an alteration in pitch of that terrain, we can challenge the structures that are involved. So that being the midfoot, the ankle, the heel, sometimes the plantar fascia, the forefoot. These are all areas that we see under fire when we're looking at these more advanced cases in the acquired flat foot, not forgetting the pediatric flat foot. And I do believe that if we get these patients at the right time, we have a big opportunity to move them out of the AFO brace and back into a custom-made foot orthosis with appropriate footwear. We also use a range of other management strategies as well. We use extracorporeal shockwave therapy in cases of tendinopathy. We may use high volume injection therapy for tenosynovitis in more acute inflammatory presentations. And certainly we cannot disregard the benefits of good quality footwear as well, both in occupational footwear and leisure footwear as well.
Yeah, well, at the summit, we're going to have a couple polar ends. We're going to have Simon Bartold, who, of course, has done a lot of stuff with shoe design. And then we're going to have also Golden Harper, who designed the Ultra shoes, which is a zero drop shoe. And, I get a lot of interesting things from both these guys. I know Simon of late has been talking about the emphasis on looking at the sagittal plane as well, because of the importance of the torques in the sagittal plane versus not having quite the same torques when we examine from the back or the front in the frontal plane. Golden, of course, is always throwing good exercises out, especially for runners. And one of the things I picked up lately was balancing on your forefoot. So it's easy enough to balance on one foot, flat-footed, sometimes closing your eyes or even challenging with catching a ball. But when you start to get on your forefoot, you're really engaging the glute medius, and those ankle muscles that go cross above the ankle. So that's something that I just started doing with my patients when they are up for more of a challenge than, let's say, somebody that might be more sedentary. Have there been any things, I guess, that you have come across that you could share with as little game changers? I've got the football field in the background. We're teeing off, as a sort of just a representation of what we're going to be doing, teeing off for our summit, symbolically. But is there anything that you have found that's been sort of a game changer in terms of specific exercises? I know you use braces. Anything else that you might want to share?
Yeah, I mean, I always speak to patients about strengthening in the posterior chain. One of the exercises that I give out for that is just a single limb hip hinge, either with or without a weight. So sometimes the weight can actually help kind of get that patient into that single leg hinge. But I try and get them to work barefoot actually in this exercise. And if they want to add a small weight, that will allow them to hinge with more ease. So that's something that personally I practice myself every day as well.
Can you
And it's a
describe it?
really,
Can you describe the exercise itself?
yeah. So
The
if
orientation?
you, so basically, the patient will just be stood in front of you. I'll get them to go into single limb support if they're able to, and then I might ask them to hold a small weight, and I might ask them then to hitch forwards, but hinging at the hip, and they're kind of dropping the weight parallel down towards the ground beneath them. And what we're looking for is for them to engage the hamstring. So they're going to feel that pull in the hamstring. So what we don't want to see is a straight leg. We want to see a slight knee bend. And when they then deviate into that forward lean position, we don't want to see that hip is altering its position either. And that's quite difficult. And I think that's one of the key exercises that I look at just in single limb support. And then equally, when we're looking at tib post strength regime, we're also looking at isometric movements. So that might just be the patient resisting the foot against an object or against the other foot. Okay, it's a non-weight bearing exercise. It doesn't require any resistance bands, and they can do that absolutely anywhere. So that's quite a good exercise. And then we start to look at eccentrics and plyometrics for sport specific. But those two, just inversion against an object, non-weight bearing, and then the hip hinging single limb support exercise for posterior chain.
Yeah, that's good stuff. Are there any particular cases that you've come across that were interesting or had a result that maybe wasn't anticipated? And I can share one with you real quick after you do yours, because you also do stuff with foot drop.
Yeah, I mean, there are patients who I see with foot drop and pes planus or acquired flat foot in the same person, in the same foot. And certainly seeing how they come into the clinic, how we progress them with a Rockasole shoe, rehabilitation, the use of the brace, but within the benefit of a Ritchie brace and not kind of outlying any other treatment options in terms of an AFO. But the unique benefit of the Ritchie brace is it has triplanar control, because essentially it has a foot plate orthosis, and that has the uprights going up the sides of the brace. So if you have a patient that has a foot posture issue, like acquired flat foot, you then also have different hinge types. So we can, for a flaccid foot drop, we can use a tamarack hinge, and that has an assistive dorsiflexion function. So I had a patient who developed foot drop from having lupus in her early 30s and developed neurological deficits as a result of that. And she's now going on to leaving the dog at home because the dog slows her down, you know, and this was somebody that couldn't even walk with any degree of balance. And I've got pre and post video analysis of her, and you know, it gives them their life back, you know, certainly if they're willing to wear it. What about you? I want to hear about your
no, that sounds like you scored a touchdown on that one. Well, I have a similar touchdown story. What happened with this particular patient is that he sprained his ankle. I think it was playing sports, if I remember correctly. Running, I think, just running. Anyway, so he developed a foot drop as a result of engorgement of the peroneal nerve up closer to the knee. We did an MRI, we did some nerve conduction studies, and there were some decreased latencies in the nerve of the peroneal. And he had no dorsiflexion essentially of his foot. So this was now 3 months. And he had tried to engage, you know, normal kind of rehab type things, just to try to sort of motor map and will the positioning to happen. So what I ended up doing, and I have one of these home, I used something called electromagnetic therapy. And it was literally a Frankenstein moment where like it's alive, because I did 2 treatments, and on the first treatment, he got a little bit of movement of toe dorsiflexion. Now he was full on circumducting and everything, like a real foot drop, you know, the classic foot drop and the compensatory management strategies. So I'll grab what I used over here. It'll probably pop up in the foreground, but this is the I call it the ring of life. So it literally is a magnetic field that is generated with copper wire through this ring, and between the application of stimulating the nerve, I quote, waking up the nerve, he ended up getting a little bit of movement. And I put the video up on YouTube so you can see his reaction. And I need to call him for follow-up, because I assume, you know, as a lot of these cases, you don't get that final story. But I would assume that if things weren't progressing on his own, he'd be in for more treatments, but literally 2 treatments. So it was a shocker to me, literally, how fast. And obviously, you know, you're not going to get that kind of result with that kind of modality every time. But the fact that it worked and it was linked to that was a biggie for me. And it was very satisfying to be able to get this guy his life back with sport. You know, he's an active, 25, 26-year-old.
Wow, that's amazing. I mean, I don't know much about this therapy.
I will certainly share it to you, and when we're done, off this little bit, I can tell you a little bit about it, because it is something that I think would be beneficial in the UK, especially with your treatment philosophies with shockwave and etc. Well, is there anybody that I don't know if you've had a chance to look at the faculty, and we'll wrap it up here. And I thank you for doing this little sort of preview of what you're going to do. Is there anything you're excited about? Anybody that you caught on the faculty? I know one of your Clifton Bradley is going to be speaking as well. I'm sure you know him. And anything in particular that you're looking forward to hearing about?
I'm really excited to hear about the, kind of
I'm excited to listen to anybody who's passionate about musculoskeletal medicine. I really am. And I think seeing what you guys are doing over in the US is really exciting. And I think any way that we can collaborate in that way is going to benefit our patients. And I think, you know, we should be working together maybe more than we are. My colleagues who are speaking, Nick Knight's a really good friend of mine. Simon, of course, I've seen lots of his work, and Clifton as well. But yeah, I'm just really excited to be involved and to see speakers from overseas.
Yeah, well, I welcome this opportunity for sort of cross-pollination. It's good stuff, and so that we're not siloed here in the US, and we're listening to what's going on in Europe and the UK in particular. So look forward to having you. It's January 24th at 4 p.m. I think you're about 5 hours, right? For me. So like I'm looking now, it's 4:39. Do you have about 9:39 over there, or is it?
I do indeed.
Yeah.
Do
Okay.
indeed, yeah.
Okay. So that's easy enough. So and I think we have your talk towards the end of the presentation, and you know, hopefully you'll be excited enough. It'll be kind of like watching the Late Show. But looking forward to it, and thank you so much for doing this this afternoon and this evening for you, Zoe.
Yeah, no problem. It'll be a pleasure as always, and I'll make sure I invigorate people at the end of the day.